Dear students and my future colleagues, welcome to the Department of Internal Diseases Therapeutics. Our subject is a clinical discipline, where it implies direct contact and interference with the patient, including, and evidently so, verbal communication as well as physical examination. I would like to bring it to your attention that the internal part of our subject's name is of utmost importance. Internal diseases include heart, lung, liver, and kidney disorders, all of which relate to the eyes of the average person without specialized medical education. And it's exactly the knowledge of our subject that allows you to make an educated assumption of cardiovascular system, gastrointestinal and respiratory diseases when examining your patient as a dentist. All of these leads us to two important conclusions. The first one is that heart, lung, liver, and kidney disorders significantly affect the condition of the oral cavity, teeth, and gums, and by extension, affect your professional routine as a dentist. In other words, in order to perform your job as a dentist successfully on a long basis, it's very important. It's of a great importance to take the specific conditions of the cardiovascular and endocrine system into consideration. The other conclusion is that internal diseases can cause acute complications that directly threaten your patient's life, your dentist's patient's life. These emergencies can't be predicted, so it's impossible to tell which arm of your patient gets into one and when exactly does this happen. They can result in a patient's death unless first aid is provided in a timely manner. The emotional strain that some patients still experience before and during visiting a dentist can sometimes result in an elevated BP, the so-called hypertensive crisis, very high level of BP, blood pressure. Or, for example, this emotional instability of the patient before visiting dentist can lead to acute myocardial infarction. And this, my dear students, is exactly why every dentist must be able to diagnose medical emergencies. This includes you, even if your original intention was to perform a routine dentistry-related tasks, such as treatment of caries, or stomatitis. Let's review an example. Your patient develops a severe asthmatic attack, serious condition with acute respiratory disorder. Lung failure is developing. Your job is to diagnose this emergency. Call an ambulance. It's 103 in Russia, and provide first aid to ensure that your patient stays alive until the ambulance arrives. In my opinion, the most fascinating aspect of our subject, if we will discuss now about dangerous and sad consequences of complicated course of internal disease, let's speak about interesting, fascinating thing. I think that's very fascinating that person with internal organ diseases can't be diagnosed, can't be interpreted, can't be grasped by a person without medical education. So, in our discipline, we'll discuss the course, the symptoms and signs, complications of diseases of the organs which are hidden from the eyes of those who didn't learn medicine. That's why welcome to our department. We'll connect near 2 years, at least 2 terms, third and fourth year. And let's start. Internal diseases therapy. Large branch of theoretical and practical medicine, which aims to study the diagnostics of disease of internal organs and especially prevention and treatment. Here is a list of areas of specialization in frame of internal diseases or therapy. You know all these words: gastroenterology, pulmonology, correspondingly GIS and lung diseases. Hepatology searches for liver disorders. Nephrology, correspondingly disclose kidney diseases. Cardiology, hematology. I won't list all of them right now, but look how many directions, how many areas are included in our discipline. And of course, main problems of modern medicine must be highlighted since first lecture. Of course, that's cardiovascular diseases and mortality from them. Malignant or neoplastic disorders. By other words, oncology is a great problem of our epoch too. Addiction, viral diseases, ADC, and ecology can be listed in the same frame of high actuality of our sphere. Some key points must be discussed right now, and they touch to main principle of medicine. And of course, you know it since first time in our university, since first year, medical history, philosophy, etc. So, primum noli nocere, well-known humanistic principle, which can be translated as first do no harm. Since Hippocrates' model, you know this principle. Next is from model of Paracelsus, do good, it said. The principles of absence of duty reflects deontological model in frame of internal diseases. And bioethics follow the principle of respect for human rights and dignity. This is old document from previous slide. Is connected with Hippocrates' model, do no harm. I won't detailize the historical aspects. You knew them. But I'd like to stress that's true. This principle is actual till today. And now I pronounce it as a clinician because of the great mission of any of you, of my colleagues, is to save patients' life and to treat them, to relieve their condition. And this process must be based on some key points, including the same. And so, despite the fact that many centuries have passed since the first, not even edition, but creations of Oath, that's not out of date till today. The oldest ethical document. The illustration. Paracelsus can be seen here. Another model of medical ethics developed in the Middle Ages. In frame of Paracelsus model, in contrary to a Hippocratic one, the main importance is paternalism, emotional and virtual or spiritual contact of the doctor with the patient in the process of the treatment. It was described in those epoch, and some points are actual and introduced in our everyday work. Deontology, with its principles, are listed here. I'll recollect it for you, but won't detailize right now. I have so many information for you connected with our direct topic, introduction to internal diseases and principles of examination of the patients. So, now, unexpected movie. Please, let's watch it and then I'll comment it.
And here we are, the granddaddy of all quantum weirdness, the infamous double-slit experiment. To understand this experiment, we first need to see how particles, or little balls of matter, act. If we randomly shoot a small object, say a marble, at the screen, we see a pattern on the back wall where they went through the slit and hit. Now, if we add a second slit, we would expect to see a second band duplicated to the right. Now, let's look at waves. The waves hit the slit and radiate out, striking the back wall with the most intensity directly in line with the slit. The line of brightness on the back screen shows that intensity. This is similar to the line the marbles make. But when we add the second slit, something different happens. If the top of one wave meets the bottom of another wave, they cancel each other out. So now there is an interference pattern on the back wall. Places where the two tops meet are the highest intensity, the bright lines, and where they cancel, there is nothing. So, when we throw things, that is, matter, through two slits, we get this, two bands of hits. And with waves, we get an interference pattern of many bands. Good so far. Now, let's go quantum. An electron is a tiny, tiny bit of matter, like a tiny marble. Let's fire a stream through one slit. It behaves just like the marble, a single band. So, if we shoot these tiny bits through two slits, we should get, like the marbles, two bands. What? An interference pattern. We fired electrons, tiny bits of matter through. But we get a pattern like waves, not like little marbles. How? How could pieces of matter create an interference pattern like a wave? It doesn't make sense. But physicists are clever. They thought, maybe those little balls are bouncing off each other and creating that pattern. So, they decide to shoot electrons through one at a time. There is no way they could interfere with each other. But after an hour of this, the same interference pattern is seen to emerge. The conclusion is inescapable. The single electron leaves as a particle, becomes a wave of potentials, goes through both slits, and interferes with itself to hit the wall like a particle. But mathematically, it's even stranger. It goes through both slits and it goes through neither. and it goes through just one, and it goes through just the other. All of these possibilities are in superposition with each other. But physicists were completely baffled by this. So they decided to peek and see which slit it actually goes through. They put a measuring device by one slit to see which one it went through and let it fly. But the quantum world is far more mysterious than they could have imagined. When they observed, the electron went back to behaving like a little marble. It produced a pattern of two bands, not an interference pattern of many. The very act of measuring or observing which slit it went through meant it only went through one, not both. The electron decided to act differently, as though it was aware it was being watched. And it was here that physicists stepped forever into the strange, never world of quantum events. What is matter? Marbles or waves? And waves of what? And what does an observer have to do with any of this? The observer collapsed the wave function simply by observing.
So you can ask me, what's for this well-known double slit experiment? The direct connection is shown. Look, first, of course, it was switched on to awake those who are bored from historical facts I listed before. But if seriously, look, it illustrates the ability to influence to the patient, if you're a doctor or dentist. Even your presence can produce unexpected positive or negative impact to your patient. Your personality, your ability to communicate, to small talk before you start your dentistry manipulation, information collection, taking history, art. It's really art, not only mechanical questioning of the patient. All these things can influence to our patients. And that's why well-known soft skills, I know you remember them, are very helpful in professional work, in either as physicians or as a dentist. Even if electrons change their orbit in presence of an watcher, can you imagine how much a doctor can achieve if his or her actions are not limited by only presence, by only passive presence near the patient? Think about it. And what's the main quality of a doctor? The question is not for rating, not for CP passing. Think, what's this? 1, 2, 3. The physician must be clever, must be smart. And next rule, which must be discussed in the internal diseases professional area, is don't go if you don't know. That's really true. That's why professional skills plus your intellect, your IQ realized in professional sphere is a great base which lead to you either perform dentist procedures effectively or diagnose in time emergency conditions associated with our area with internal diseases, the complication which needs your immediate solution as a professional. And now some words of importance of first communication. Look, when you met next patient first time, you must get the maximum of information about his health, diseases, to realize your specific procedures at the best level. And for internal diseases, for organs which hidden from unprofessional sight, first effective communication can give all the necessary to suspect preliminary correct diagnosis. I pronounce preliminary because of course, after communication, after patient's questioning, inspection, and other methods, which will be discussed later, we can't guarantee 100% reliability of our diagnostical opinion, but good professional physician can suspect the correct diagnosis, correct opinion about disorder of patient's health during first visit, at least at 90% of cases. And another side, look, I especially touched the soft skill. Yeah? So near 80% of diagnoses are made on taking history alone. If you can ask patients correctly, professionally, with all the realization of all the symptoms and signs, if you support good psychological background, if your communication can reveal all the facts, principle for the cause, for the appearance of the disease and future treatment, that's okay. You get 80% of your diagnostical opinion at the background of first communication. I don't know what about dentists here. I am discussing now my professional area, internal medicine. And here, the effective communication with the patient at the background of symptoms and signs collection, anamnesis morbi and vita, by other words, taking history, is of great importance. A common maxim in medicine, the famous person said, just listen to a patient. He's telling you the diagnosis. As is for aphorism, it's true. Because of careful history will lead to the diagnosis 80% of the time. The word diagnosis comes from the Greek word able to recognize. That is, diagnostics in medicine is the process of recognizing diseases. And often, not only health, but also human life depends on recognition in time. If there are symptoms that suggest the presence of any internal disease, or when the patient has health complaints, but finds it difficult to describe the cause of the sickness, the examination is carried out in accordance with approved of your country protocol for diagnostics of internal diseases. A general clinical examination is aimed at a detailed study of the patient in order, step by step. Specific scheme exists to make your life easy in general clinical examination. And the result is the identification of specific pathology that caused sickness and problem with the patient's health. Clinical examination of the patient is a step-by-step system of medical methods and techniques. In turn, I'll list them: questioning, anamnesis. Anamnesis is named taking history. History of the disease, which is the main for this patient in this time. History of patient's life. Then physical examination. Then lab and imaging studies. Sometimes consulting and a specific procedure to verify complicated diagnosis. Clinical examination is the basis of diagnosis. It's a material and physiological foundation of diagnosis. And without it, it's quite impossible to guess what's wrong with liver, kidneys, or lungs. And we are starting since questioning. Of course, patient will complain on some problems. He can pronounce different words to describe his or her disorders. And you must choose among all the information the main symptoms, main signs of the disease, and consider them in frame of possible organs damage. So, subjective examination is grounded on the patient's impression about his or her disease. So, it will take into account the patient's information. That's why it's named as subjective. Taking of symptoms and signs in Russian therapeutic tradition, this chapter named as complaints, but in English books you can meet since first page the chapter symptoms and signs, they are the same. Then detailed history. 2 chapters in our medical school are appeared. Anamnesis morbi, history of the disease, all the details, the way which was realized since first sign till today when you are contacting with the patient and when you are communicating with him. Then analysis vita, patient's life history. You should analyze the patient's lifestyles, habits, occupation, hazards, family history of diseases, and the same and the same. The main task of the doctors when taking history is to reveal all the details of the patient's complaints. Because patient has no medical education, as a rule, of course, exclusions are available, but as a rule, there are no medical education. That's why person will be responsible only for his or her impression about these signs. You must detailize them. When, how much, what's intensity of these symptoms, when appeared, what are provocating factors, what are trigger factors, what are relieving factors. So all the information must be gathered during first communication to perform next step to diagnosis. Objective examination is quite direct responsibility of doctor only. It reflects doctor's impression about patient's health. So this is physical examination, and it includes first visual inspection, examination of skin, sclera. For your work, oral cavity inspection is of a great importance. Yeah. So then another skills which are realized by physician are palpation, percussion, and listening to the patient's breathing, if we're considering respiratory system, or auscultation with stethoscope. On this stage, an experienced doctor can assume the causes of disease and preliminary localization. And then, after this objective examination, after physical examination with the doctor's skill realization, a physician will prescribe additional methods to prove or to exclude his first diagnostical opinion. Pay attention, the well-known Latin word nota bene. Yeah? Pay attention that 90% of objective information for the diagnosis doctor can get since first examination. And this is anatomy of respiratory system. I decorrect it for you as the part of our lecture will be connected with the examining methods for respiratory system, bronchi, lungs. So I'll recollect to you the general impression of it. Bronchi, then alveoli with acini, and some specific words must be discussed, must be defined before we start communication and the respiratory disorders problem. The main mission of respiratory system, you remember its function, yeah, is oxygenation and elimination of CO2. There are two connected processes, and such terms must be learned. Hypoxemia means low level of oxygen in blood, arterial one. In contrary, hypoxia means decreased level of oxygen in the tissues. And look, hypoxemia, heme is a blood by Greek, yeah? So it will be directly connected. Hypoxemia means low oxygen in the blood. Hypoxia correspondingly decreased level in the tissues. Hypercapnia means increased level of CO2 in the blood. And hypo correspondingly decreased one. And now I get attention, please. Dyspnea. A patient can pronounce, I have difficulty in breathing. I can produce bad breathing. It's hard to breathe today. I can't perform deep inspiration or expiration. But all these complaints can be summarized in such universal term, dyspnea. Any difficulty of breathing, any disorder of inspiration or expiration will be named by this term. Very convenient to detailize the complaints and to guess what's here, what area is more involved in the pathology process. Tachypnea means rapid rate of breathing. Cyanosis. Cyanosis means bluish color or sometimes grayish color of skin due to bad oxygenation of the blood. So, using the known terms, we can tell that cyanosis is developing due to hypoxia. Deficiency of oxygen in tissues will produce such specific bluish or grayish color of body. And hemoptysis means expectoration of blood in sputum. All these terms I need to use them in our professional communication in our future practical classes. I'll your teacher in seminars. That's why let's adapt your forces to future internal disease practical classes. So, and if we are considering respiratory system, I'd like to list the main complaints or main symptoms in case of respiratory diseases. So, if lungs or bronchi damaged, patient will complain to the cough, breathlessness, or dyspnea. I prefer term dyspnea. Chest pain, pleuritic chest pain, I must add, wheezing, attacks of dyspnoea, hemoptysis, and sputum production. These complaints more or less connected with respiratory system proper. That's why if you mark them or if you collect them after first communication with the patient, you can suspect with a great reliability that lungs or bronchi are damaged. So your primary contact with the patient was finished with suspicion on the damaged system. That's great. This is the name of first meeting, first communication, doctor-patient. What should you do with these complaints? If this patient is your dentist patient, Before you start any procedures in oral cavity, think about these problems. Are these signs life-threatening or dangerous for the patient health or not? I'll help you. If hemoptysis appeared before dentist manipulation, stop all the plans immediately. You must ask for the help for emergency because hemoptysis is life-threatening complaints. Next question you must be asked by you. Is the first aid necessary immediately or not? If hemoptysis, yes. If chronic cough during some years, episodically, after physical exercises, not actual now, maybe not. But solution is your responsibility, not the patient's one. Next question. Can you start to perform your stomatological procedure or not? Look, I'm discussing all the universal situation. If you are waiting the patient, you didn't start else, you analyze these complaints and you make solution. Will you perform some manipulations, some procedures or no? If you are working in the oral cavity, you are treating caries or you are planning the tooth extraction and some serious complaints appeared, you must stop the procedures and correspondingly take all the measures to save patient's life and health. Fourth point, what are preventive measures? For example, if patient has allergy for example, some, let it be penicillins, antibiotics, think about possibility of the same contact in your room. Of course, I think you won't use penicillins at all. They are not tactile in your sphere. But for any case, think about possibility of contact with, I don't know, bad smells, some another allergens, and the same. So think about preventive measures if you met person with some complaints. Then, can you help him to relieve pulmonary signs if present? For example, if patient produces dyspnea on exertion and he was tired when he's running to your dentist room to be in time, of course, let him to have a rest. Check, are there dyspnea or no? And after resolution of this symptom, you make conclusion about your future manipulations. And last, what are possible recommendations to diagnosis or treatment about these respiratory disorders? So this scheme is useful, seems to be, for any dentist or future dentist because of the work of any doctor is unpredictable. Let's detailize some key points. So, cough and dyspnea. They are universal. They can appear in any disease of respiratory system. I can list them. Bronchial asthma, bronchitis, acute bronchitis, or COPD, chronic obstructive pulmonary disease. Then pleurisy or pleural effusion, tuberculosis, pneumonia, lung abscess, any disease of lungs and bronchi can produce cough and dyspnea. But not only respiratory problems are associated with them. Dyspnea and cough can appear in cardiovascular pathology. For example, in patients with heart failure, when the main pump of his organism doesn't work properly, it can be accompanied with dyspnea due to cardiac problems and cough. Hemoptysis. I spoke that's a very serious complaint. The presence of spot of blood, even small volume, after cough, is a life-threatening condition. Hemoptysis can be massive, frank, or it can be only traces of blood after cough. What are possible diseases which can lead to appearance of such complaint? At the first place, of course, tuberculosis. Then bronchiectasis. This problem means enlarged and deformated bronchi in human body. Lung cancer can produce hemoptysis too, and pulmonary infarction, which has a plenty of other serious symptoms and signs, is associated with hemoptysis too. So the wide spectrum of these disorders needs specific diagnostics to not only to stop hemoptysis immediately with specialized aid, but also to prevent next time hemoptysis. Wheezing, by other words, rhonchi. Wheezing can be had at the distance. Sometimes so expressed disorders in bronchi developed that it can be had without doctor's equipment, without stethoscope. This wheezing will be distant, and the most typical cause is attack of bronchial asthma, the classical student's variant of wheezing. But also this phenomenon is typical for chronic obstructive pulmonary disease, COPD, exacerbation. It won't be an attack, as in case of asthma, but chronic course of this disease can be accomplished by wheezing too. Now let's watch, then I'll comment. Do not pay attention of the Russian comments. I'll explain all the key points, but look at the patient's position, pay attention of the placement of his hands and arms in general, and try to hear the specific sounds named as wheezing. Some problems. Excuse me, I'd like to correct it. I promise to switch on it during our classes. Chest pain. This sign can be developed in patients with pleurisy, pneumonia, angina pectoris, pulmonary infarction. Chest pain accomplished the pleurisy is associated with a breathing phase. So, if pleurisy developed, patient will complain on the pain worsening in deep inspiration or with a cough. This is diagnostical because of pleural involvement has a specific feature, connection with a deep respiration and with a cough. Other types of chest pain will be discussed later to avoid the mix in your mind. And here, this is important slide, yeah? 100% indication for emergency. To call for you, yeah? First aid emergency in case of pulmonary disease. First. Now I'm discussing the person who is your dentist patient, who is waiting, I don't know, caries treatment or tooth extraction or periodontitis treatment, but he developed such symptoms. So let's list the most dangerous symptoms and signs which are of 100% necessity to get emergency first aid. Progressive dyspnea. If dyspnea appeared unexpectedly, it will be very serious. Next, attack of dyspnea, especially with a wheezing. It means the presence of bronchial asthma attack. Maybe not. But to solve this problem, emergency is indicated. Hemoptysis. Severe and acute chest pain. If patient asked to remove your hands from the oral cavity and he felt so severe pain that he can't continue, it's direct indication to ask about emergency help. Syncope, stroke. Stop any dentist procedures and save the patient's life here. I stressed that taking history is more than 50% of diagnostics. So, how should you ask the patient? History taking must be performed systematically, step by step. In turn, recommended question will reveal new informative facts which can help you to put diagnosis or to suspect it. Especially for you as a future dentist, please pay attention on history of allergy. Ask patient by different words. Had you have any allergy? Can you use all the drugs? Had you any problems with pharmacology, with smells, with pollen, with, I don't know, any allergen you know? Because of some patients can forget, can do not think about it right now, but contact with unexpected trigger in your presence can produce serious allergic side effects. That's why think about it before you start any manipulation, any procedures which can be complicated by, for example, bronchospasm due to allergy. And special attention to the anesthetics. You know that old-fashioned anesthetic produced allergy in high percent of cases. That's why Novocaine, lidocaine quite are not actual now because of high risk of allergy too. So ask person before anesthesia, if any, about side effects including allergy in his history. Inspection. Before this slide, we spoke about subjective facts from the patient's biography, from her history, because of they were the patient's impression about symptoms and signs, analysis morbi and vita. But right now, let's start since a relatively objective point, inspection, visual information which can be get from the patient, and look in our internal diseases. That's quite possible. That's quite possible to get a plenty of facts to interpret important change of patient's condition since first sight. Yes, that's really. And look on this picture. Such position is very typical for patient during asthmatic attack. So, if patient developed asthmatic fit, he or she will take the same position. He won't lie down. He won't agree to lie if you ask him to do it and show the bed. No, of course. He won't agree because in this position, named forced position, he felt a bit better. The essence is that in this posture, the work of additional respiratory muscles became easy. I hope you remember respiratory muscles. The main are intercostal, external, internal, and diaphragm. Do you remember? I hope yes, you passed anatomy, And additional muscles are sternocleidomastoidus and pectoralis minor. And their work is easy in this position. It named in English books as tripod position. In Russian book, it's described as a forced position in sitting or semi-sitting, with based on the bed or chair arms. Another variant of forced position in attack of bronchial asthma. Bad quality, but visual information can't be supplemented by my words. Another fact which can be considered during physical examination of the patient are the shape of his or her chest, the form, the shape. Compare two persons, they are different, yeah? First is neurasthenic, but right person has the barrel chest. The shape of his barrel is the same to the barrel, yeah? Such phenomena, named as emphysema. You can hear such term in pathanatomy and other disciplines. So it means the increased air containing and following deformation of the chest. And experienced physician can diagnose emphysema since first sign by visual examination only. Another key points of general examination are based on respiratory rate. You can check dyspnea objectively by rate per minute. Count the respiratory rate. Don't pay attention the patient that you try to count respiratory rate, because he or she can control respiration plus minus. Yeah, we can stop our breathing and the same to avoid artificial correction of respiration. Do not ask patient about it. Only count how many breathe in and breathe out he performed per minute. It will be respiratory rate. If more than 20, for example, it will be tachypnea. Tachypnea is a frequent respiratory rate, and it proves the presence of dyspnea. Dyspnea is complaint, is subjective sign of patient's from the patient, but respiratory rate counted by physician is objective sign and confirmation of dyspnea at rest right now. Second point, cyanosis. We spoke that it means the bluish or grayish color of fingers due to bad tissue oxygenation. So these bluish fingers are typical for cardiovascular disorder, for heart failure, because of the peripheral cyanosis is typical for person with heart disease, in heart failure. But in respiratory disorders, patients have diffuse, homogenic, and more grayish than bluish cyanosis. But in any case, even if you are unexperienced person, you can guess, does it mean cyanosis or no, since first sign. And look, the secret information. You are examining oral cavity. Cyanosis is remarkable in mucous membranes. That's why any dentist can be specialist in color of mucous membrane. The more patient you examine, the more dentist procedure you performed, the more experienced you are. Yeah. So each case will add some information to your susceptibility of visual information. So some months or years after, you can diagnose cyanosis in oral cavity and other change of color with a high percent of correct impressions. Yeah. Peripheral cyanosis in heart diseases at the left photo. That's more typical for heart I'd stress it again, this principle remains, please, and named as acrocyanosis or peripheral cyanosis, when only then fingers and lips are the most bluish. Peripheral cyanosis. I promised to switch on distant wheezing, so try to hear the wheezing. That's normal respiration then. Here. Next visual information is in your professional area, yeah? Tongue changes, mucosa, bluish color is here. Can you see? Bluish lips and bluish tongue. This is cyanosis too. Plus specific rash on the face didn't connect it with our today topic. Pay attention only on the oral cavity, lips and the tongue. Another finding in general examination in case of respiratory disorders are the following. Clubbing of the fingers. Picture, the figures inform you about it with great impression. Such advanced disorders are available in bronchiectasis. I spoke that's deformated and enlarged bronchi. Lung abscess, pulmonary fibrosis, and cystic fibrosis. Look, that's remarkable, even for dentists. I'm sure that you'll mark it, if any, in your future patients. This is a list of respiratory diseases. We'll speak about them, and investigation methods must be discussed too. Physical examination is performed after taking history with symptoms and signs, disease history and life history, and after inspection. Physical examination includes these methods: palpation, percussion, and auscultation. I prefer to detailize them during our practical classes. As an example, I can show you the different sounds which can be produced by respiratory system if pathology developed. That's interesting, informative, and it is valuable. Sometimes can be heard at the distance. That's why in your work you can hear it, even if without stethoscope. So on your duty, during your work. That's why we'll discuss it with all the details on our practical classes. And now, objective examination must be based on the following results of imaging studies. How to diagnose of pulmonary disease with a high percent of reliability. You must prove your first diagnostical opinion by objective methods. And I'd like to start since the most informative, visualizing, pretty, if I can speak so, method X-ray examination. Any pulmonary disease must be proved by X-ray, even if there are no X-ray signs of this disease. X-ray investigation is obligatory to exclude the hidden problem, to differentiate respiratory pathology with another one, and the same. So the first line method, the first line study after physical examination is, of course, X-ray. Look at this picture. I don't know had you radiology or no, but in any case, the person who passed anatomy can see some anatomical structures here, is it? Ribs are seen as the white lines, anterior, 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 posterior, posterior, posterior part of lungs. This is mediastinal organs. Heart shadow can be seen. Diaphragm is placed at the right and at the left. And radix of lung can be seen at the both sides too. Right photo is very different from the first one, yeah? Look, the intensity of lung pattern is different at the left, at the right. But even you, without specialized knowledge, can see some key organs and elements of the chest. Is it so? I especially show you this photo, and then right now I'll recollect to you the anatomy of lung that's useful either to learn diseases of respiratory system and then diagnose them and save the patient's life and health if any met in your work. And second, it'll make easy the following interpreting of your professional stomatological X-ray films because of in dentistry, X-ray investigation, CT, X-ray, and all other methods are of a great actuality. So the more films, the more electronic sources with X-ray you see, the more experienced you are. So let's recollect, then I help you to interpret this pathology. They have severe pathology, trust me. So lung anatomy on the chest X-ray. Let's remain first here with a normal anatomy and all these things.
Here's what a normal chest X-ray looks like. It can look intimidating at first, but coming up with a systematic way of reading your X-rays can help simplify things for you. So, over the next few videos in the coming weeks, we're going to review how to read the chest X-ray. So let's start with some basic anatomy that you'll need to know going forward. Here's the trachea, typically in the middle and branching into the left and right main stem bronchi. Normally, you'll see a steeper right bronchus compared to the left. Next, you'll see the lungs. The right lung is divided into 3 lobes by the horizontal fissure and the oblique fissure. The left lung is divided into 2 lobes, also by an oblique fissure. When I'm assessing the lungs, I also look at the surrounding pleura and then the diaphragms on both sides. The diaphragms should have a curved shape to them, and sharp costophrenic angles. The right diaphragm should be higher than the left because of the liver, and on the left, sometimes you could see a gastric bubble, which you could see here underneath the left diaphragm. If you look closely in the lung fields, they're not completely black. You will see fine strands of white in them all the way to the edges of the lungs. These are the pulmonary vascular markings and will come in handy later when looking for things like pneumothoraces or a collapsed lung. Let's go over the bones next. I usually start with the clavicles to see if they're equidistant from each other, which is important in determining rotation of the X-ray that you're looking at. You may also notice the manubrium between each clavicle. Here are your scapula and humerus on the right and left side. Notice that you don't see the scapula overlapping your lung fields. That's because properly obtained plain films should have your scapula out of the lung field views so that your lungs are unobstructed by layers of bone and soft tissue. The next set of bones I look at are the ribs. I usually quickly count them off myself, since this will give me an idea of whether or not the patient had enough inspiration when the X-rays were obtained to get the most optimal view of the lungs. Lastly, for your bones, in the middle you will see the vertebrae and spinous processes. Note that you could even see the vertebrae behind the heart, which signifies adequate penetration of your film. And finally, let's go over the heart. It typically lies to the left of the patient and should be less than 50% of the thoracic diameter. Here, you'll see the superior vena cava adjacent to the aortic arch. Flanking the heart, you will see pulmonary vasculature spreading out into the lungs. And here, you will see the chambers of the heart. Here's the right atrium, the right ventricle, the left atrium, and left ventricle. So that's it. That's the basic overview of the anatomy of the chest X-ray. If you haven't already, make sure to subscribe to this channel so that you'll get updates.
So, I hope it was useful. The same is with the teeth, but they are smaller. Yeah, that's true. Dark means air-containing tissues, white means high-density ALS tissues, and the same. Look at this film. Good. Can be see as a normal X-ray. Pretty, symmetric. Then this patient has widespread pulmonological problem, pneumonia. You can hear this word many times, yeah? Many times, especially during last 2 years. But look, how to suspect pneumonia by unexperienced vision. Fortunately, we have two lungs, left and right. That's why if patient has symmetrical organ, we can compare left and right side parenchyma. And look, this patch is whitened. Density of this patch is increased in contrary to the same, to the left one. So one side shadow. This pattern can be described here. So this patient has pneumonia at the right side pneumonia. Pneumonia, by the word, has specific definition. Some slides later, please. Pneumothorax. What does it mean, this horror word? This patient has an air instead of lung in pleural cavity at the right. Look, what's wrong? Left lung is relatively healthy. Lung has vascular marking and the same. But at the left side, there are no lung in peripheral areas. 2/3 of lung are occupied by an air. And lung was collapsed, and you can see the shadow of it in medial area, you see. So this patient has severe life-threatening condition named as pneumothorax, air in the chest, properly in pleural cavity. That's why air in pleural cavity led to collapse of lung and impossibility to restore its volume into breathe effectively. By other words, this patient has 50% of function of respiratory system. Guess, my dear students, what's the main complaint, what's the main problem for this patient? If one lung works properly only, 1, 2, 3, dyspnea, severe dyspnea due to absence of respiratory parenchyma at the right at all will produce severe dyspnea. Second, chest pain because of damage of pleura, the rupture of it to produce pneumothorax, as a rule, is accompanied with severe chest pain. Next, this patient has barrel chest, and barrel is due to ability to analyze this lateral view really as a barrel, yeah? And this shape is quite squared. In contrary to previous one, I will try to remove, this. Compare with the size and shape of these lungs, yeah? And then this one, quite squared. In addition, except emphysema, another pathology developed here, but I won't mix all these things. Look, you can see barrel chest due to emphysema, and you can diagnose it and remain. All other things will be detailed after. To compare with pathology, I placed the normal X-ray at the left, and at the right you see quite all the right lung has shadow. Shadow means white tissue, high density, airless tissue in 2/3. It's probably pneumonia, but much more massive than previous one. Left side pneumonia can be diagnosed. Another patient, he has problem at the right side. Upper right lobe is infiltrated. Inflammation is developed. So we must consider either pneumonia or, frequently for upper lobes, tuberculosis. All these pictures are to explain you the necessity and valuability of X-ray investigation in our professional area. Pulmonary diseases can't be diagnosed without it, and even you, with first sight to films, can divide some pathology, can find some problems, especially if you use the principle comparing of the left side and right side. Here is very expressed shadow. This lungs has a plenty of small shadows. Sometimes they combine, sometimes isolated, round, yeah? A plenty disseminated shadows can be seen at the right. Maybe enough. I promised to comment first film. Do you remember? Before I showed you the principles of interpreting of lung anatomy on chest X-ray, you can see this film. Let's look on these two patients after previous information. Left side. This lung has severe lung abscess, a round shadow with a transparent center. This is X-ray picture of lung abscess, gigantic, yeah, compared with the diameter of mediastinal organs. And this patient has square shape of chest, dark lung parenchyma, And these shadows are symmetric and they are due to breast. Do not pay attention on them as an object to be interpreted. So, lung parenchyma is darker than on normal. Spaces, intercostal spaces, are enlarged. Their position, their placement is quite horizontal. So, this square chest, of course, that's barrel shape, you remember. So, this patient has emphysema. I can speak about it many times, but it's necessary to discuss another method except chest X-ray. Who knows? 1, 2, 3. CT scan. So CT scanning is of great informativeness, very detailed impression about lung parenchyma, radix's content, the spreading, the dynamic of inflammation, the presence of small areas of destruction which can't be seen on chest X-ray. All these details can be seen on this method. Computer tomography allows to define less expressed pathology than chest X-ray. That's why the general principle of optimal diagnostical reliability is to define methods correspondingly their findings. If patient has such lung abscess, it can be seen even on the plain chest X-ray without any exotic methods. Should you prescribe him computer tomography? Maybe yes, maybe no. But now I discuss only the fact of presence of this pathology. If you can see the problem and the developed film, literally, of course, it will be electronic one, there is no necessity to verify this opinion by CT. But if you are not sure in course of this abscess, if you can suspect cancer, which is destroyed and forms some area of destruction, you can prescribe exact method, next step diagnostics, to verify your suspicions. The principle is the following. So CT scan is much more informative. Compare their results. Here we can see both side damage and the placement, the level, the stage of involvement can be detailed from film to film on CT. Large area of destruction can be seen here. Look, this patient has lung tissue destruction too. And this one, and this, and this. And right side too. Look. Tuberculosis will produce cavities too. Do you remember the complaint on hemoptysis? Since first slides devoted to patients' complaints in respiratory system. So hemoptysis is not rare in TB. That's why the cause of this phenomenon is the destruction of lung tissue. If cavity is forming due to TB, it will be produced destruction of arteries, of vessels in general, and correspondingly expectoration of blood with a sputum. CT can prove the presence of small cavities, which can be seen on chest X-ray. What's here? Look in the arrows. This one. And plenty of changes here. Heavier inversions. This patient has polycystosis. Another disease, yeah? This is the results of this one. Oh, here you can guess, seems to be. Look, we spoke about shadows in airless tissues or decreased air containing. Do you remember pneumonias and the same? They were white due to less than a norm air containing. But here you can see both sides, CT, computer tomography, with dark spots, dark areas, without vascular and lung patterns. You see? What conclusion can be done? More or less air containing? Of course, more, because heart has no air and it's dark white. If air is increased and air containing is increased, it will be the same. White heart has no air, dark space has air only without respiratory tissue. A large volume cysts as a bullous can be seen here. So cavities, plenty of cavities, are diagnosed by emphysema. No lung parenchyma here. Lungs tissue can be seen abroad of them. So a plenty of dark spots are connected with the presence of air containing areas. Another example of investigation, you can see shadow here and in this sample, and area of lung tissue destruction appeared again. This dark round finding is the cyst in lung. But look, where is it? It can't be seen or on chest X-ray. Or can? Can. This thin wall space is susceptible to pathology. But the best diagnostic is realized with CT usage. Round clear space found in the left lobe is proved by this method with a great reliability. Next method is spirography, the measurement of ventilatory function of the patient. On the right side, you can see the results of it. But how to perform the technique? This method helps to evaluate the ventilatory function of lungs, especially bronchial permeability. You know, bronchospasm or contraction of smooth muscles in bronchi is available in some diseases. For example, in bronchial asthma, in COPD, in acute bronchitis. If patient has narrowed respiratory tubes, if he or she developed bronchospasm, it will be associated with disordered expiratory function. Look, if you right now perform deep inspiration, breathe in, then breathe out, your healthy bronchi became narrow during expiration. That's why in any problems of in bronchi, the first problem will appear during expiration. That's why if you met the patient with bronchial problems, such as bronchial asthma, the radix is bronch, bronchitis acute, chronic obstructive bronchitis in frame of COPD, they will complain on first expiratory dyspnea, then they have disordered expiration. They can't perform breathe out effectively. And this test can help them to realize it. Let's look at the technique of spirometry.
Today we're going to be doing a spirometry test with you. Your provider heard a wheeze, and so we're going to see if that wheeze has an abnormal pulmonary function test. So basically how we're going to start the test is you're just going to relax and breathe normal for me. After a bit of normal breathing, I'm going to have you take your deepest breath. You got to pack in as much air as you possibly can, and then blast it out as hard as you can, as long as you can as well. You're going to squeeze, getting out all your air. And when you have it all out, take the breath back in as hard and as fast as you can. I'll talk you through each step of the way. There's going to be some flashing lights. When it turns green, I want you to put it in your mouth and start breathing. I'm going to put a nose clip on so you can't breathe through your nose. Relax and breathe as normal as you can. After a couple normal breaths, when you're ready, take your very deepest breath. Pack in as much as you can. Big breath, now blast. Go long, keep going. Squeeze out all your air. Now, big fast in. Great, nice job.
So, the results of this test will be printed with indication in percent of all the respiratory volumes. The idea is to measure maximal volume of air which can be expectorated during forced expiration, as you have seen. Moreover, this method can be used to define the efficacy of some medications. Bronchial asthma, in case of attack and acute respiratory disorder, when patient is sitting in tripod position, as you saw, and he produces distant wheezing, as you had in the appropriate video. In this situation, emergency includes the inhalation of bronchodilator. This drug will lead to relaxation of bronchial smooth muscles and, as a result, bronchodilation. The most famous drug here is salbutamol, beta-2 agonist, which can realize effect in some seconds after inhalation. So, if we reproduce spirometry after inhalation of bronchodilator, we can check how effective this drug for this patient. That's very valuable information, you can guess, yeah? So, this technique can allow you not only prove the presence of respiratory disorders, but to consider their type of most effective drug, for example, and a plenty of other abilities. So, spirometry can check efficacy of some drug. It named as reversibility because bronchodilation means, after inhalation, means ability of bronchi to be relaxed quite immediately, yeah? So it means a reversible respiratory disorder, proved by spirometry. Another technique for at-home control of respiratory symptoms and signs is peak flow meter. This equipment has the same purpose as spirometry and the same technique is performed, but it's portable. It's convenient to be taken in the car, in the backpack, in bag, and it allows to measure respiratory function at home without repeated visit to the clinic. That's very convenient for patients who needs unstable control upon bronchial permeability, for example, in COPD, in asthma. So let's look at another technique with quite the same abilities. You see, this is small and that's convenient to be near patient in any situation.
A peak flow meter measures how fast and hard you can blow the air out of your lungs. Before each use, make sure the sliding marker is at the bottom of the numbered scale. Stand or sit up straight with your chin slightly lifted and look straight ahead. Keep this position for the entire time. Blow out and empty your lungs as much as possible. Breathe in deeply to completely fill your lungs with air. Put the mouthpiece between your teeth and close your lips tightly. Do not put your tongue on the mouthpiece. Blow out as hard and fast as you can through the mouthpiece. The sliding marker will move up the scale. Look at the number on the meter to see where the marker stopped. Repeat the steps and measure your peak flow 3 times. Record the highest number you reached. Be sure to reset the meter to 0 before each time that you blow into the meter. Keep a record of your peak flow number around the same time each day for 2 weeks while you are feeling well. The highest number is called your personal best peak flow. Your asthma action plan will use your peak flow numbers and give instructions on how to treat your asthma based on your symptoms and peak flows.
And now I'd like to discuss another approach to diagnostic, endoscopy. Equipment for this procedure is available in bronchologic and pulmonological departments, and it means the ability to see the problems inside of respiratory system. That's valuable, you see. And this method, visual examination of bronchi, can be complicated by, not complicated, excuse me, can be added by biopsy taking. And in parallel, you can not only see the possible tumor, even small size, but also to get biopsy for specific study for cytology, to make conclusion about presence of atypical neoplastic cells and volume and stage of this cancer. That's why endoscopy in our frame is bronchoscopy is a valuable method. Let's look.
Bronchoscopy, examination of your airways. You will be called from the waiting room and take a seat in the examination room. Before the procedure begins, the physician or nurse will numb your throat with a local anesthetic spray. Because of the sedation, your throat will start feeling swollen and stiff, and swallowing will become more difficult. Next, an anesthetic fluid will be dripped into your throat and the trachea. Your tongue will be pulled slightly outwards in the process, which may cause you to cough or gag. The physician will carefully insert a camera-equipped tube into your airways via your nose or mouth. This is called a bronchoscope. The physician places a mouth guard in case the bronchoscope is inserted via the mouth. During this procedure, some patients are given extra oxygen through a tube that is inserted into the nose. This may cause an annoying itch. During the procedure, you can keep breathing normally through your nose or mouth. The physician will use the camera on the bronchoscope to look at the inside of the trachea and the bronchus. Mucus, scraping, or tissue may be collected for further laboratory examination. Sometimes the airways are rinsed with a fluid. After the procedure, the physician will slowly remove the bronchoscope from the airways. The procedure can feel uncomfortable, but it usually doesn't hurt. To ensure that you are as relaxed and comfortable as possible during your bronchoscopy, you can choose from amongst a variety of sleeping aids in addition to the throat sedation. To find out more, take a look at this animated film, Sedation for Bronchoscopy.
You see, I especially have chosen the technique with explanation for the patients because of we'll learn all the terminology, all the professional slang and details of our medical language slightly later. That's why it's easy to suspect things to be maybe such simple but emotionally colored movie. I hope it's helpful instead of dry, many words description of this technique. Yeah. And now I'd like to welcome you in the world of robots. So, in real life, now it's possible to perform robotic bronchoscopy. Let's look at the next series of our film. Look, I hope it was at least interesting for you. Yeah? Technically, our internal medicine is very interesting, is unpredictable, problematic, needs plenty of skill, but fascinating area of medicine. So, welcome to our club of those who know and understand internal diseases. See you next time. Best wishes. Goodbye. Thank you for your attention.